Hello friends. Today we're going to discuss about traumatic brain injury. I'm Dr. Suresh Padadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about traumatic brain injury, the definition, signs and symptoms, what are the different pathophysiological concepts and definitions of traumatic brain injury, epidemiology, and also I'll be discussing about an important study which was published in Lancet, that is, findings of the Lancet Commission with regard to TBI and also the recommendations. First, let's discuss and define about traumatic brain injury. There are various definitions with regard to traumatic brain injury. The well accepted definition is here. Traumatic brain injury refers to an injury to the brain that results from a sudden and an external force or a trauma. Please remember here, the external force or trauma is essential. This TBI can range from mild to severe, depending upon the extent and the severity of the force and also the location of the brain damage. Invariably, for mild TBI, they call it as concussion, whereas moderate and severe, they are simply called as traumatic brain injury. All TBI are not concussion. Only the milder version is called as concussion. The common causes for traumatic brain injuries commonly are falls, especially in elderly population, road traffic accidents, sports related injuries, assaults, especially domestic violence, and military combat related injuries. TBI is increasingly documented not only as an acute condition, like as soon as the injury, but also as a chronic condition which has a long term sequelae, which has including increased risk of late onset neurodegeneration. That means head injury does not have only acute consequences. The people who survive will have long term consequences, not only with the same person, but also the whole family suffers. Traumatic brain injury affects multiple domains of the life. It affects not only the person, and the person may develop disability. It will affect the family life, occupational life, social, biological function, and also the quality of life of the person and also the whole family. Further, there are various studies which have clearly associated traumatic brain injury and criminal offense. It's bidirectional in nature. Various epidemiological studies done in developed countries such as Sweden, Canada, Australia indicated approximately 2 to 3-fold increased risk of serious crime in individuals after traumatic brain injury compared to people who did not have TBI. That means there is some amount of relationship between criminal behavior and TBI. Invariably, the people who are involved in criminal activities may end up having head injury because of violence. But at the same time, the people who are not criminal at the point but developed head injury may develop aggression and also sometime emotional dysregulation after the head injury may end up in conflict with law and they may be arrested. Hence, it's bidirectional in nature. However, please remember the presentations of TBI, signs, symptoms, and outcome of traumatic brain injury can vary widely depending upon various factors such as severity of the injury and also the specific area of the brain affected because of the head injury, what is the primary injury sequelae, secondary injury sequelae, what was the premorbid level functioning of the person, legal issues, insurance involved, and promptness of medical intervention. All these play an important role with regard to presentation and also the outcome. Let's look into these three important factors which play a role. The traumatic brain injury, the signs and symptoms depends upon the occurrence. That is, whether the injury is directly related to primary injury, that is, the force which caused head injury. It may be penetrative injury or maybe a blunt injury. Secondary injuries are that is secondary to the after the head injury. That means the consequences of hypoxia, there is no blood supply, there may be increased uh, ICT, that is intracranial tension, hemorrhage, Various other pathophysiological factors affects after the head injury. Location of the injury. The head injury in the frontal lobe differs with regard to head injury in the temporal lobe. So diffuse injury may present differently, and focal injury may have a focal presentation with focal neurological deficit. Severity. More the severe the injury, the more the severe will be the presentation. Whereas there may be open penetrating injuries and sometimes close penetrating injuries. Let's discuss each one of them. So, before we enter into that, we need to know the pathophysiological concepts of traumatic brain injury. Let's discuss about primary and secondary. What is primary brain injury? Primary brain injury refers to the sudden and profound injury to the brain that is considered to be more or less complete at the time of impact. That means as soon as the impact occurs, the force which is involved, which causes the brain damage, is called as primary injury. That is, it happens at the time of accident or at the time of injury. That is, maybe car accident, vehicle accident, gunshot wound, or fall. That means at the time of the injury. Secondary injury is refers to the changes that evolve over a period of hours to days after the primary injury. That means there is a brain injury occurred. Subsequently, what are those secondary injury which occurs when the treatment is not given in time, or else the wrong treatment is given, or else the prompt treatment he did not receive? It includes entire series of steps or stages which occurs at the cellular level, at the chemical level, physiological level, tissue level, blood vessels, those changes which occur in the brain that contribute to the destruction of the brain and also various cognitive function. That means, although we need to prevent primary injury, but many a time it is simply impossible. But the secondary injury which occurs after hours to months, that needs to be treated promptly. So the outcome also depends upon secondary injury. So this is how we can see the primary injury and secondary injury. The primary injury is the injury, the force which occurred at the time when the force was exerted on the brain, like skull laceration, skull fracture, contusion, cerebral laceration, intracerebral hemorrhage, that is penetrating injury is there, or diffuse axonal injury, that is at the time of the injury. Secondary injury which occurs maybe minutes to hours to months. So that is after the primary injury. That is because of this bleeding which occurs in the skull. Intracranial pressure may increase. Because of this, hypoxia may occur. Hypotension may develop. Hypothermia, electrolyte imbalance, toxic amino acids, oxygen free radicals. So, or even the infection which occurs because of the open injuries. So, the outcome may differ. So, the important part of treatment in TBI is preventing secondary injury. Now, let's look into the how the primary injury and the secondary injuries are related. You can see in this diagram there is a traumatic brain injury subtypes. So, the injuries can be either focal, that is very specific to one area of the brain, otherwise, the diffuse. Diffuse is commonly seen whenever there is a blunt object involvement, or else the head banged against the floor or maybe to a flat surface. There, a mild injury can cause concussion. There may be diffuse axonal injury, or else the blast which occurs because of various weapons or maybe bombs, or else shaken baby which occurs with the parents when they are abusing the child, or else sudden whiplash injury sometimes may cause. Whereas in focal, it will be a penetrative injury where it can be contusion or penetration because of the knife or a bullet. And then subsequently, after the primary injury, there may be hematoma which can be formed on the epidural or maybe in the subdural, maybe in the subarachnoid space, maybe even the intraventricular later or intracerebral, the bleeding which occurs subsequently. So these are primary and secondary. These which I have marked are the secondary. But the pathophysiological mechanisms which occur in the secondary injury need to be understood. The commonest is structural axonal injury. What happens? Whenever there is a force, sudden force is exerted on the brain, invariably there will be disruption of the cell membrane or maybe blood brain barrier. This will lead to the intracellular fluid, and the cellular mechanism may disruption occurs, and the fluid may move out of the cell. This will cause severe edema. So this can be seen in white matter. So invariably, secondary oxotomy may be there, axonal injury may be there, edema which can be occurred because of microtubular fracture, and also axonal transplant impairment may be there. Further, there may be, because of this edema, blood flow may decrease. This may lead to hypoxic injuries, or else further oxidative injury may occur, or free radical injury may be occurring. Further, acute axonal, over a period of time, acute axonal degeneration may be there, Valerian degeneration, dying back pathology can be there. Further, over a period of time, because of the injury, amyloid, beta amyloid may be deposition may occur, tau protein may be occurring. Then, because of this disruption, the white matter disruption may occur, which leads to network dysfunction, impaired brain region connectivity, cerebral edema, as I mentioned, blood flow may be decreased, necrosis, apoptosis, and degeneration may start. As I mentioned, mitochondrial permeability pore may worsen, further reactive oxygen, which is oxidative related injury may develop. So these all, along with the inflammations, cytokinin, chemokinin, phagocytosis, along with this, my dear friend, if imagine there is an infection to the brain, this will cause further damage. So these are the secondary injury mechanism which need to be identified, and also proper appropriate treatment to be given. Now let's discuss about the open versus closed traumatic brain injury. In closed traumatic brain injury, there is no breakage of the skull, that is fracture of the skull, that is non-penetrating injury to the brain. A closed brain injury is caused by a rapid forward or backward movement and shaking of the brain inside the closed bony skull that results in bruising, tearing of the brain matter, and also blood vessels. Whereas open traumatic brain injury is a penetrating open end injuries which results because of the fracture of the skull, that is foreign body object entering into the skull, bullet piercing the skull, maybe depressed fracture forcing the skull entering into the brain parenchyma. Now let's understand focal versus diffuse traumatic brain injury. Focal TBI happens when there is a specific well circumscribed area of the brain is involved in the injury, that is penetrating injury of the knife to the brain. Diffuse is, it is a generalized type, unable to pinpoint any specific area which is damaged to the brain, which is diffuse axonal injury is the sharing or the tearing of the brain's long connectivity nerve fibers, that is axons, that happens when the brain is injured as it shifts and rotates inside the bony skull. So here it is more of shearing of the brain movement which causes the diffuse axonal injury. At the same time, you need to know coup and contrecoup injuries. A coup injury occurs around the site of the impact with an object. That is, if you look at the coup injury, there at the site of the injury, that is, if the strike occurs, especially if a person is traveling the car and suddenly the car stops because of an accident, then the passenger will go and hit his head to the dashboard. So this is the coup injury where the injury occurs at the frontal lobe. And suddenly, after that, the person will be thrown back. This causes countercoup injury, which occurs in the occipital area. That is, opposite side of the area where it was hit. So please remember the coup and countercoup injury, you may find the person has been injured in the frontal area, but you may have to look into the occipital area because countercoup injury may be there. So both needs to be seen. Many a time, inexperienced doctors may think the injury is only in the frontal lobe. Invariably, there may be countercoup injury which is occurring in the occipital lobe also. Now, we discuss about the classification of traumatic brain injury based upon the severity. The severity of the traumatic brain injury is based upon Glasgow Coma Scale is one of the methodology has been used. The Glasgow Coma Scale, which is done within the first best 24 hours, what is the scoring that is to be taken? So as you know, there are three important parameters that is called as EVM, like you can remember is electronic voting machine. So E is for eye opening, V for verbal response, M for motor response. I is scored over 1, 2, 3, 4, and that is if there is no eye opening, none. To pressure, it is 2. To the sound, 3. For spontaneous opening is 4. So the minimal score is 1 and 4 is the maximum score. More the lesser the number, the severe is the injury. More is the number, better is the prognosis. With regard to verbal response, if there is no response at all, response to sound, response to words, confused, oriented. So, based upon the response, here you will be rating the person. Again, the worst is if he does not respond at all, the minimal score. The more the minimal score, severe is the injury. Similar to motor response. If there is no motor response, if there is extension, abnormal flexion is 3, normal flexion is 4, localizing is 5, obeying command 6. So please remember, in this, the minimal score is 3, the maximum score is 15. In a mild traumatic brain injury, the score will be within the range of 13 to 15. In moderate injury, it is 9 to 12, and in severe, 3 to 8. So, based upon the Glasgow Coma scale, it will be considered that the severity can be done. However, based upon various other parameters nowadays, the severity has been considered not only for the rating the severity and also the prognosticating the case. Let's look into the symptoms of the traumatic brain injury. As I mentioned earlier, based upon the severity of the force, area of the brain involved, not only that, the person's premorbid functioning, all those play a role. But however, at the acute presentation, the patient may have loss of consciousness, that is coma, is unconscious, is on the road, or else is awake but loss of awareness. He does not know what is happening around him. That is loss of awareness. Many a time headache, altered behavior. Because of the injury, there may be seizures, vomiting and nausea because of increased ICT, clear fluid draining from the nose or maybe from the mouth, difficulty in awakening, lack of coordination, numbness and weakness of the extremities, paralysis, mood swings, confusion, maybe slurred speech. These are the commonest symptoms when you see immediately after the head injury. Other domains of the symptoms can be divided into 5. They are physical symptoms, sensory symptoms, cognitive symptoms, emotional, and behavioral. Let's look into the physical symptoms: headache, neck pain, dizziness, easily fatigued, numbness. Sensory symptoms: sensitivity to light, sensitive to sound, blurred vision, double vision, loss of state, loss of smell, tinnitus, ringing in the ear, abnormal sounds in the ear. Cognitive symptoms: memory problem, difficulty in attention and concentration, difficulty in word finding, difficulty in sequencing of information, various other cognitive deficits may be there. Emotional symptoms: easily agitated, mood swings, difficulty in controlling the emotion, emotional dysregulation, feeling of guilt, depression, anxiety may be there. Behavioral symptoms may be impulsive behavior, verbal output, maybe outburst may be there, physical outburst, becoming violent, getting lost easily, and sleep disturbance can be seen. At the same time, the effect of brain injury can be short term and long term. Short term I had already discussed, such as loss of consciousness, loss of awareness, confusion, disorientation, headache, nausea, blurred vision, tinnitus, changes in sleep pattern, mood swings, memory lapses, depression, anxiety. Long term effect of head injury can be seizures, higher risk for blood clots, infection, building up of fluids in the brain, migraine, headaches, head eye, hand eye coordination difficulties, memory loss, cognitive difficulties or disabilities like memory impairment, attention concentration impairment, easy fatigability, speech problems, tinnitus, anger management, insomnia, maybe psychiatric symptoms may be seen. Now let's look into the epidemiology of traumatic brain injury, that is incidence and prevalence. Across the world, TBI, is a leading cause of injury related to death and disability, with the devastating effect on the patient and their family members. The cost of care of a TBI patients and also loss of income, the global economy around the world is simply 400 billion annually US dollar, my dear friends. It's not one or two, 400 billion dollar, my dear friends. Approximately 50 million to 60 million people have traumatic brain injury annually. That is 5 to 6 crore. Of all common neurological disorders, the TBI has the highest incidence and prevalence, and this poses a substantial public health burden in the society. If you look at the chart with regard to incidence and prevalence, the purple pillar are the incidence and the green pillar are prevalence. When you compare incidence and prevalence with regard to head injury, stroke, Alzheimer's, Parkinsonism, and multiple sclerosis, the TBI, the incidence and prevalence is huge. 50 to 60 million people are having TBI annually. That is 5 to 6 crore, my dear friends. Both incidence and prevalence are huge. So, it is a public health emergency at this point of time. Let's define the traumatic brain injury based upon the severity. Although I had discussed about based upon the Glasgow Coma scale, that is useful for initial staging of the disease, but for prognosticating the case and also for various insurance purposes or medical legal purposes, the 5 parameter assessment is important. What are those 5 parameters? First one is imaging. Second one is all loss of consciousness. Third one is altered consciousness, post-traumatic amnesia. And the fifth one is Glasgow Coma Scale rating. If you look at the imaging either by CT scan or MRI, if it is mild, invariably it is normal. But however, normal CT scan even can be seen in moderate and severe injury, and it can be abnormal. So if there is an abnormal, either it is moderate or severe. Though CT scan can indicate whether the surgery has to be done or not, or staging of the disease based upon the first day and second day, whether the rebleed is there, whether the operation is done or not. Those are the issues which will be able to prognosticate using CT scan or MRI. But however, other parameters are essential, such as loss of consciousness immediately after the head injury. If there is loss of consciousness for less than 30 minutes, it is mild. If it is less than 1 day, it is moderate. If it is more than 24 hours, it is severe. With regard to altered consciousness, what does it mean? The person is not lost consciousness, but is disoriented. He does not remember where he is, whom he is talking to, and is completely disoriented. If it is less than 24 hours, it is mild. If it is more than 24 hours, either it can be moderate or severe. If you take post-traumatic amnesia, that is after the head injury, what is the memory deficit? If it is less than 24 hours, it is mild. If it is less than 7 days, it is moderate. If it is more than 7 days, it is severe. Moving to Glasgow Coma Scale, that is first 24 hours, which is the best recording. If the scoring is between 13 to 15, it is mild. 9 to 12, it is moderate. And severe is less than 9, my dear friends. This is the rating which is adapted by the management of concussion or TBI work group. So this is a very important, which is used for prognosticating the case. Invariably, the milder injury of traumatic brain injury is around 90%. Moderate to severe is hardly 10%. That means 90% of the patients who has head injury will have score between 13 to 15. But however, although there is a 10% who have moderate to severe injury, they require admission, surgical intervention, insurance support, long-term rehabilitation, and also may require disability pension for the long term. However, there may be 90% of traumatic brain injury which are mild. Although they are mild, around 50% of this mild traumatic brain injury do not recover to the premorbid level. That is, pre-injury level, they do not reach at all. That means they have some deficits. They may develop disability. They may not be able to achieve the occupational functioning within 6 months, my dear friends. That means 50% of the mild traumatic brain injury do not recover 100%. Let's look into the traumatic brain injury and research. The TBI is often characterized by both an acute mental incapacity because of the end injury is either loss of consciousness is there or disorientation is there. Hence, he is not in a position to give consent. At the same time, doing research in an emergency situation looks unethical. Imagine a person has head injury and you want to do research and you're looking for to take consent from the family members or to the patient. Is it right or is it wrong? It has its own perspective, but for the larger public, invariably it says you have to do best to save his life. Hence, it looks unethical doing research in acute emergency stage. Further, 90% of them have mild traumatic brain injury. These invariably lead to medical legal issues, and the person who examines and treats them invariably will be called to the court of law to provide evidence. This many a time in many countries, calling the doctor, asking him to wait in front of the court hall, not providing adequate compensation for his time, harassing the doctor to come many times. Doctors are fed up going to the court. Although it is their duty to go to the court, unfortunately, many countries do not respect the time of the doctors. Hence, many doctors avoid seeing traumatic brain injury because of legal issues. Not only that, it can be medical legal, many a time, police interrogation, and if something goes wrong in acute emergency case, violence against doctor is impeding them even to do clinical care, forget about research. Hence, research in traumatic brain injury has suffered because of these various factors. Further, research with regard to plasma biomarkers for mild TBI is slowly being accepted. Invariably, any head injuries in the metropolitan cities are subjected to CT scan. And invariably, 90% of them, there will be no structural changes. Exposing 90% of them to X-ray radiation of CT scan, is it ethical? Is it clinically right? Is the biggest challenge. Hence, there are various plasma biomarkers which have been approved by various countries' regulatory agencies, such as FDA of America, CE mark of European countries have approved glial fibrillary acidic protein, ubiquitin carboxylase, terminal hydroxylase L1. These are the various biomarkers have been approved before putting the patient on CT scan. Invariably, you can decide CT scan after 12 hours of mild TBI. If there is increase in this protein, then you can decide and put them for CT scan. Otherwise, you can defer CT scan based upon the biomarkers. Hence, my dear friend, instead of putting everybody to CT scan based upon the severity, based upon the clinical signs and symptoms, you can do the plasma biomarker. Later, you can decide about CT scan. Now, let's look into the traumatic brain injury, how the presentation occurs in high income countries versus low and middle income country. Traumatic brain injury in high income countries invariably presents because of fall. High income countries have geriatric population are more, and hence it is considered as low energy mechanism of injuries. Here, geriatric patients will fall and invariably they present to emergency or casualty. And invariably 30 to 40% of them hospital who are injured will be hospitalized. Invariably, the outcome is dependent on based upon the comorbidity of the geriatric patient, how frail are they, alcohol abuse and other substance abuse will dictate the outcome of traumatic brain injury in high income countries. With regard to disparities of care, even in high income countries, can be seen if an elderly patient presents to the casualty. Many a time, they may be denied of admission, or else they will be discriminated compared to the young patients. And many a time, the surgeons may do not take any risk because of the comorbidities the elderly patients may have, and these decision making is not based on evidence. The acute care given to young patient versus the geriatric patient in high income country, 30 to 40% are not being treated adequately. However, if you look at the traumatic brain injury in the low middle income countries, here maximum patients report are because of high energy mechanism injuries. That means road traffic accidents, such as vehicular accidents, who are either maybe a pedestrian or maybe a passenger or maybe two vehicles who are at high speed collide each other. And invariably, they are considered as high energy mechanism injuries, and invariably young people are involved. Here again, you can see the substantial disparities in care exist from one center to another because of lack of emergency services, availability of ambulance, availability of neurosurgeons, availability of ventilators, availability of OT, CT scan, MRI. Hence, the treatment is delayed. So, the mechanism of presentation between high income countries versus low middle income is different. In high income countries, it is geriatric. In low middle income is younger generation who are involved in high energy mechanism of injury. Let's look at the prognosis of traumatic brain injury. The prognostic models which have been proposed are invariably for moderate to severe. With regard to mild, there are very few models. But whatever models we have, let's discuss that. Especially with regard to moderate to severe injury is based upon the age, Glasgow Coma Scale, extracranial injuries, polytrauma injuries, alcohol intoxication, substance abuse, gender of the person, education, pre injury mental health of the person, whether he is well adopted or not. Broadly speaking, the prognosis of mild TBI is driven to an extent, greater extent, what the patient brings to the injury. That means, in milder patients, more than all the above information, the information how premorbidly or pre injury condition of the person dictates the outcome in mild TBI. Whereas in moderate to severe TBI, various other parameters play a role. I'm not denying even in mild TBI they play a role or not, but the premorbid level of functioning plays a role in mild TBI. But however, this has been contested because of insurance, because of the disability the person produces, and also the compensation to be given. Invariably, the insurance company will contest, telling that it is a mild traumatic brain injury and the disability shown is disproportionate to the injury and also the presentation during the acute condition. Hence, there has been a model which has been proposed that is called as BPSC model, that is bio, psycho, social, ecological model. What is B biological? Biological is what is the severity of the brain injury, what is the host response, where is the site of the injury, what is the genetics of the person. Psychological is, that is, what is the coping skills, mental health resource, resilience of the person. S is the social support, employment, whether he has money to pay, whether he has insurance to pay, what is the family support. Ecological is what is the healthcare systems available in that place, whether he had adequate resources, timely availability of ambulance, availability of neurosurgeons, very good neuro or nursing care is available or not. This BPSC model plays a role in the outcome. This you can see in this diagram. You can see the A, that is basically we are talking about the outcome in this diagram. Here you can see the biological model which I discussed about brain injury, severity and host response, psychological which is the coping skills and mental health resource, ecological is the healthcare system, social support. And based upon the traumatic brain injury, the outcomes will be decided based upon these four important parameters, my dear friends. Further, prognostic models have been developed well with regard to moderate to severe, whereas there is no well validated model with regard to mild TBI, that is, concussion cases. We do not have good prognostic indicators. The reason being the research is very less with regard to mild TBI, and many mild TBI patients do not report back to follow up. That means we miss them for follow up, or else, many a time, the neurosurgeons do not have time for the mild TBI case and they say for follow up, if you have any problem, only report, otherwise, need not come. Now, let's look at the recommendations of the Lancet Neurology Commission report on traumatic brain injury. These recommendations are based upon the how the responses and also various research and also the data which have been collated across the centers, and various centers have contributed for these recommendations. There is a wonderful publications which have been published in the Lancet by Andrew and his colleagues. Please go through this publication, which you will be able to understand the traumatic brain injury and how it affects in the public health sphere. Their recommendation starts with there need to be a concentrated efforts with regard to addressing the vast global health problem with regard to traumatic brain injury. That means there should be concerted effort by the all members of the society to avoid traumatic brain injury. It may be prevention, promotion, and also secondary and tertiary prevention, that is rehabilitation. Focus should be on prevention, improved access to care, promotion of clinical research to improve the treatment standards should be the important goal which need to be decided. Especially in high income countries, the citizen fall, especially the elderly citizen fall, should be avoided. Further, deliver on implementation of road safety in Islamic countries based upon the World Health Organization Decade for Action on Road Safety Plan of 2021 need to be implemented in all developing and underdeveloped countries. Improving the emergency pre-hospital care and develop an infrastructure for post-acute care, that is rehabilitation for the patients who have undergone surgery or maybe who had severe head injury. Collaboration with policymakers and clinicians is essential to invest in avoiding head injuries, providing care and rehabilitation. Improving the access to rehabilitation services both in high income country and Islamic country is the need of the hour. There is a need for evidence based treatment procedure for long term problems with regard to mild TBI is the need of hour. With regard to fatigue, cognitive changes, behavioral changes, neuropsychiatric changes need to be observed, especially in mild TBI, and treated. What is the outcome need to be studied. There is no well documented prognostic model for mild traumatic brain injury. We need to implement care pathways to ensure structured follow up, especially with mild traumatic brain injury, because there is a lack of data for the course and outcome of mild traumatic brain injury. There is a need to stimulate research with regard to mild traumatic brain injury. Who are those patients who have poor outcome? Who are those patients who have good outcome? What are the interventions which need to be done so that there is a good outcome even in mild traumatic brain injury is the need of the hour. Hence, there should be evaluation, follow up, and those data need to be shared across the country so that the evidence base can be done strongly and recommended across the country. We need to develop a good regulatory mechanism for research, especially in traumatic brain injury. The reason being, the head injury patient may be not in a position to give consent. Doing surgery in emergency situation may look unethical. Hence, a regulatory mechanism to protect the neurosurgeon for doing surgery or a research should be in place. There should be mandating that the researchers obtain proof of mental incapacity or capacity and taking the consent, and also involving the study participants or else the users, the society, and it is very essential with regard to end stage or maybe vegetative state conditions, withdrawing life support need to be discussed involving the society. There is a need for public health interest, establish a research focus on mild traumatic brain injury, gender difference, older patients with the TBI should be the focus in the upcoming field and also in the near future, my dear friend. To conclude, traumatic brain injury is a leading cause of injury which related to death and disability across the globe. Approximately 68 million people suffer from traumatic brain injury. Out of that, 90% are mild TBI, 10% from moderate to severe. Although 90% are there with mild TBI, invariably 50% of them do not recover premorbid level of functioning. Progress has been with regard to incorporating novel clinical variables across the globe with regard to blood biomarkers, characterization of patient, severity of the patient, prognosticating of the patient, neuroimaging of the patient, coming with the standard protocol of imaging, studies, and also treatment has been there. But however, the challenge is the treatment, implementation of this protocol, investment in prevention of road traffic accident, providing care, providing access to rehabilitation are the biggest challenge. High income countries need to focus on geriatric patients fall, how to avoid fall, and provide adequate treatment is the important component they need to focus and avoid discriminating them when they come to the emergency care. Whereas low and middle income countries are struggling to provide care for the patients who come with road traffic accident. Access to treatment, access for neurosurgeon, access to neuroimaging, access to standard protocol is missing. Hence, they need to implement WHO standards for road traffic accident for next 10 years and come up with a plan, and also policy and investment should be stronger. So, my dear friends, LAMIC countries have larger role to play because the young people are meeting with road traffic accidents, and that is in the epidemic proportion at this point of time. There is a need for having a standard protocol treatment across the centers, and availability of resources and human resources is essential. So, this is about traumatic brain injury, my dear friends. Thanks for giving your valuable time. Stay safe.